Assalamu alaikum. Welcome everyone on board. Uh, Today we will just try to uh, have few words about what sort of questions, what sort of knowledge you need to crack the scenarios which are commonly asked in anesthesia exams or like common things that you need to know with reference to cardiovascular system. Okay, so first of all, actually, this is I just try for the first time AI. I just put the how to evaluate the severity of cardiovascular disease during perioperative anesthesia assessment. So I don't know what I got. Usually, so before going to these things, just let me explain to you in a. So Wakar, are you ready to answer? Who among you is the exam candidate? One I know, Wakar. Who else is exam candidate? Just raise the hand, and if you are interested to speak out. Okay. So if you are not interested, let me start. Actually, the whole of the cardiovascular system commonly asked scenarios or diseases which are being asked. Is one of them is ischemic heart disease. One of them is valvular heart disease. The most common is hypertension, and then heart failure. The heart failure is actually a broad term. Heart failure may be systolic failure, diastolic failure, congestive heart failure because of liver problem, because of kidney problem, because of pulmonary problem. So it's an open, and then cardiomyopathy. Okay. So these are commonly asked, and then cyanotic heart disease or congenital heart diseases. So usually these are the things which are uh, usually being asked in the scenarios. There may be some more things. So I'm just trying to chalk it out with that what your brain should be exercising, what things you need to know about it. Okay. Then among the assessment, if you want to assess the cardiovascular system, of course, for any assessment, whenever you want to tell, they can ask you, or even if they don't ask, the first purpose for you as an anesthetist, or if you are anywhere, because maybe some other specialty people are also listening to me, the basic purpose how to evaluate cardiovascular system. Okay. So what are the parameters? Whenever you are evaluating cardiovascular system, there are certain parameters you will be looking at. Of course, you will say history, examination, investigation, and risk stratification, but commonly go to the very, very basic. There is something which is called as blood pressure. There is something which is called as stroke volume. There is something which is called as SVR. Okay. There is something which is called as preload. Okay. There is something which is called as afterload. Okay. There is something which is called as contractility. Okay. There is something which is called as sinus rhythm. Okay. So stroke volume, heart rate. So these are common things. Whatever we are looking at, usually these are the parameters which you are saying. Then, because heart is a box of four doors, so there are some communication. Okay, so you have some valves. So you must be knowing about valves. Valves, they are opening, closing nicely. Okay. Then no, no, but like in our early phases, we are interested in listening to the sounds, and we are very happy to listen to the murmurs. But practically now, actually, yes, if you are in a medical forum, yes, they still may be listening, interested to listen to the murmurs, but actually now the objective assessment is has bypassed these murmurs. So now it's era of echo. So echo will tell all the murmurs and everything because the results of anything is in the so sounds, valves, then chambers. Okay, whether the chambers are good or not. So maybe I missed something, but I'm just giving you an overview how you evaluate cardiovascular system. Because whatever you are doing, looking at, and then these things will be apparently appear how they will appear in history. Like there may be shortness of breath, there may be chest pain, okay? There may be palpitation, okay? There may be dizziness, there may be, you can syncope, edema, okay? Cough with sputum. There may be hoarseness in case of left atrial involvement. Okay, it may be pressing. So, like we will just try to look it out because maybe I'm missing something because I'm just trying to give you an eye overview that usually these are the things which you should be knowing. So there will be some sign symptoms. There will be some points, the parameters, okay, which you will be looking, and these are the common diseases. So what you are saying, then if you go to the labs, so there are majority these are things, electrical activity with ECG, okay, or you can say Holter, okay, simple blood pressure, and then we use ambulatory BP, okay, with also with reference to ECG or Holter, maybe if there is some problem, there are some arrhythmias, maybe there are pacemakers. Okay, okay. And now because pacemaker actually have become AICD, so they are doing. And now with emergence, something more advanced, there may be left ventricular assist device. Okay, or now some go to some more modern. Maybe you have transplanted heart. Okay, so these are usually common things which you should be looking at. So Holter, pacemaker, AICD, LVADs, transplanted heart. Okay. Okay. So blood pressure, there are different ways to measure the blood pressure. Of course, you should be knowing that simple ways by palpatory method, auscultatory method, and oscillatory method, and the advanced is the intra-arterial blood pressure. Okay. Of course, we are evaluating. This is something else, but usually how we proceed, because there will be some monitoring or evaluations which we are doing intraoperatively. So we will try to cover in AIBP. There is another AIBP, intra-aortic balloon pump. So one is invasive arterial blood pressure, and the same abbreviation is for intra-aortic balloon pump. So it is also AIBP. So IABP. So you should be thinking about it. And intraoperatively, we also measure cardiac output. So these are the things which you are doing, or T, not only simple echo, T. So, but practically, if we have any, what else we see, go for ECG, go for exercise tolerance test, okay, and then we do now latestly CPEX testing, cardiopulmonary exercise testing. Then something else is thallium scan, or more commonly called as a stress thallium, and then simple echo and stress echo, okay. So and then angiography, okay, and cardiac CT. So you should be knowing that these are all to look into evaluation. So whenever you are evaluating, you should be knowing what is the next step. Okay, you find something in ECG, what is the next step? You will go for exercise tolerance test or thallium scan, or according to the scenario, if the patient cannot go for invasive testing, and you have to pharmacological stress rather than physical stress. Okay, so if you find some perfusion defects, thallium scan, then okay, you have to go for angiography, or you have to do cardiac CT. Some things which are not directly related, there are certain investigations. Before then, there are some enzymes. One are some acute enzymes, and some are like for markers like ANP, BNP, okay, and the CPK, CKMB, TROP-I, TROP-T. So these are the cardiac enzymes. So these are the things which you have to evaluate. Echo, there are so many points. I will touch in detail, but a very important thing is echo. Whether it is a stress echo, whether it is resting echo, or whether it is transesophageal echo, or whether it is focused echo, which is part of POCUS, POCUS, point of care ultrasound. So this is the future. So because in that you see the fluid responsiveness to vena cava compression, compressibility. You look at the cardiac chamber contractility. So this is, you can say, focused echo. It is a little bit different from the simple TTE or TEE. TTE is transthoracic echo, TE is transesophageal echo, because this focused echo will give you abrupt results and it will change the management. Okay, so these are the things. What else? What else? Cardiac investigations, chest X-ray. You will find cardio shadow enlargement, or you will find some crackles. Sorry, this lines. You will find something, chamber enlargement or something. You can find with reference to, actually it will relate it to not only the cardiovascular system, but you will also look into the pulmonary system. So chest X-ray. So these, because why it is important to evaluate or understand these things, because without them you cannot understand these diseases. So if you have got a scenario of valvular heart disease, or you have a scenario of ischemic heart disease, or if you have a scenario with hypertension, you should have a very clear concept of what's going on. If you don't understand this thing, how will you evaluate? Okay. um, I hope you guys are with me. If anything you want to clarify, either you can speak out or you can write in the chat box. I'm just trying to give you a concept, because the problem in the exam is not that you don't read. It is said that eyes cannot see what mind does not know. So what I'm trying to tell you is, I just want you to learn what is the concept, because if you understand the concept, you will be able to answer the questions. Otherwise, you will just waste time and you will not be able to grab the concept. So this is the purpose which we are trying to do. So I think I have missed some points about the examination. In the examination, the cardiovascular system examination, we just do the inspection and percussion and palpitation and auscultation. As I have told you, not a number of things have changed, but still there are certain signs. Dipyramidal testing, yes. This is actually thallium scan. What is MIBI scan? Can you tell? I just slipped out of my mind.
Yes, sir. Sir,
What is
yeah, this
MIBI?
is the methoxyazobutyl isonitrite, sir.
Is it thallium scan? Is it like for perfume effects?
Yes, sir. For diagnosis of the coronary artery
Yes, sir.
diseases.
So I think this is in the list of thallium scan,
Right, sir.
if I'm not wrong, because I'm not a cardiologist. Okay. So I think it is for perfume defects, if I'm not wrong. Maybe just correct, if wrong, just you can Google it and let me know. Okay. So, but this is the concept. There are certain things in examination, as I told you, that you have to examine the percussion, you have to examine but actually practically now it's history, because practically we don't waste our time in these things, but sometimes some things are very important. Sweating. Okay. More of the things are coming with the acute management, whether it is intraoperatively or in post-operative, like in no, either in perioperative period or in emergency. But certain things like sweating, signs of low cardiac output. Okay, this is very important. So, and then of course, one thing is this JVP, raised JVP. Okay, and there are maybe certain, because I'm giving you an idea. You can just cover it up if I have missed anything. So because we have to cover a lot of things, so I'm just trying to. So maybe physical signs, you will find some more signs in addition to murmurs, this sweating, shortness of breath, as I told you, orthopnea, PND, cough with sputums. I have told you a number of things. Okay. So now practically now, if we just go, because if you understand these things, now the coming scenario will be very easy for you. Okay. Like for
Sir,
example,
edema too.
but
Edema. Very
edema
good.
I have told in here. Edema
Right,
I
sir,
have
right. I
told.
missed it.
So edema, either it will be edema I written here. Okay. Edema, whether it will be pedal edema, sacral edema, or
Peripheral
edema,
edema.
like in the eyes, facial edema. Okay.
Right, sir.
Very good. Anything else? Anything else? Palpitation, shortness of breath, chest pain, dizziness.
Sir, hepatomegaly?
Sorry. Yes. 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 So, hepatojugular reflux, hepatomegaly. Okay. So, okay. Okay. So now we will just start with hypertension. Okay. So you will find the simple details. Uh, what is the classification of hypertension? Okay. What are the causes of secondary hypertension? What is the pathophysiology of hypertension? Okay. These are the things which actually practically you will be reading, and these are cramming stuff. But I will just give you an idea that you can find the latest WHO classification, class 1, class 2. I don't want to waste time on this thing because these are just numbers, and people are afraid there is some new classification coming. They will not fail you. You can say that this is the last one, GNC 8 or 9 or whatever is right now the latest one, you can tell. Okay. The basic purpose is that when the class 3 hypertension will be the one which is dangerous. So elective case will not be done in class 3 hypertension. Okay, this is one important thing. And you should be know the consequences of hypertension. That what if you have a patient with hypertension, what are the problems related to it, and how, as an anesthetist, you should predict and you should manage. Okay. So whenever the word hypertension come, yes, pathophysiology is important. Usually it will be revolving around either the blood volume. Okay. Either it will be regarding about on cardiac output and SVR. So these are the things which are important. So you should be knowing that there is a low role of aldosterone. Okay. So there is increased sodium retention, water retention, and then the cardiac output
Sir,
is
sir, I have a
SVR is,
question.
yes, yes,
Sir, do we also remember the different types of hypertension like malignant hypertension, resistant
yes,
hypertension,
yes,
refractory
yes.
hypertension?
Yes, actually, these terminologies are important, but believe me, this is not failure point. Because the thing is that, again, I tell you, there are some acute. You should be knowing what are the acute effects of hypertension. So acute effects are usually pulmonary edema, heart failure, stroke. Okay. What else can occur acutely?
Sir,
MI. Okay.
yes, sir.
Will be MI, stroke, pulmonary edema.
Arrhythmias.
Very good. Arrhythmias. Because MI will be in the form of either failure, arrhythmia. Okay. So usually these are actually related to MI. Okay. Because arrhythmias or failure or ischemia will be linked together. Okay. So actually, if you will go in details, there you will find even more things. Okay. But I'm just giving you at the moment. I'm just giving you a concept. So it's nice that you are recalling, because these terminologies will not be there in every book. Every book will be writing accelerated hypertension, malignant hypertension. So so the basic chunk you should understand. So if they are asking you these things, you should be knowing how to manage it. What will be the consequences? So I have told you the consequences which can occur in these scenarios. Okay. How to manage it? Like what are different antihypertensive medications which you can use in perioperative period? Well, this is one question you should be knowing. What are the different antihypertensive medications? So you should be knowing about beta blocker, calcium channel blocker. Okay. This AC inhibitors, diuretics. Okay. So you should be knowing in which patients which things will be preferable, in which patients you are choosing what things, and what are the complications which are associated with the use of specific medications. Okay. Like for example, if the patient is taking ACE inhibitors, so the things related to ACE inhibitor, prolonged hypotension, and this angioedema, and this dry cough and things like that. Okay. So these things will be evaluating. So the one more important thing with reference to hypertension is you will be seeing the patient having microvascular and macrovascular complication. Okay. So you microvascular complication in eye and kidney and autonomic neuropathy. Okay. And macrovascular complication in the form of stroke or TIA. peripheral vascular disease,
Atherosclerosis.
and sorry, ischemic heart disease.
Atherosclerosis, sir.
Yes, atherosclerosis is there for the result of all three. As
Right, sir.
atherosclerosis will result in ischemic heart disease, peripheral vascular disease, or cerebral vascular disease. Okay. So cerebral vascular disease will result in the form of stroke or TIA. Peripheral will result in peripheral claudications, and ischemic heart disease will result in either angina, MI, or heart failure. Okay. So these are interrelated things. So whenever they are asking you a question, so your answer should be that hypertension with its duration, compliance, pathophysiology, and microvascular and macrovascular complications in the form of retinopathy, nephropathy, autonomic neuropathy, stroke, peripheral vascular disease, ischemic heart disease. So if you use this word, then you can explore your answer if they want to. Okay, like the same thing which we have discussed, the same findings will be there, and you can put it fill it here. There will be chest pain, there will be shortness of breath, there will be signs of failure, there will be cough orthopnea. If there is failure, there will be edema and this and that. Okay, there will be arrhythmia, there will be so, and then you can tell, if you reach up till here, then you can say you will do ECG, resting ECG, and then as I mentioned to you. Okay, so if you understand what is going on, then it will be easy. Okay, so this will be another step, and another more important, as I told you, the medications. Okay, so usually whatever medications our patient is taking is usually to decrease the cardiac output, to decrease the contractility.
Sir,
Okay,
basically supply and demand.
no, that is something else. Yes, you are right. Demand supply is there. Demand versus supply is there. But I'm talking about the control, the treatment of hypertension. Okay,
Right, sir.
so whenever they are, so either you are decreasing the cardiac output and decreasing the blood volume. Okay, and you are decreasing the contractility. Okay, and like you are decreasing the SVR. So these are the things which you are trying to do. So you can just think that AC inhibitor, it will decrease the preload, it will decrease the cardiac output, it will decrease the afterload, because it's vasodilator. Similarly, beta blocker, it is decreasing the contractility. Calcium channel blocker, it is decreasing the SVR. Okay, so that is how you will be thinking, and all the diuretics, they are decreasing the blood volume. Okay, so this is the basic concept. Then you can go in the details of what is amlodipine, what is verapamil, what is deltazem. Usually deltazem and verapamil, they are used for cardiac problems, and not hypertension. Usually they are used for cardiac rhythm problems or cardiac this is what is myocardial demand supply. Okay, so ACE inhibitors, ARBs, and calcium channel blockers. So you should be knowing the mechanism of action, the anesthesia relevance, and the drug like this interactions. So whenever patient is taking ACE inhibitors, there may be hyperkalemia. If patient is taking beta blockers, there may be hyperkalemia. There is resistant bradycardia. Okay, there is a profound hypotension. So these are the things which you should be knowing. If the patient is taking simultaneously this cardiac calcium channel blocker or beta blocker, there may be chances of patient going in heart blocks. So these are the things you should be considering. Okay, so you will not say only I will look into the way how is the drug compliance. You have to tell these things as well, because all the antihypertensive medications, they are affecting the cardiac output, they are affecting the contractility, they are affecting the SVR. So all anesthesia medications are doing the same thing. So you have to look into it, what's happening. Okay, so the thing is that, and also it is related to the complications, because whenever there is microvascular and macrovascular complications in kidney or in autonomic system, like there are sudden swings of blood pressure. If the patient has uncontrolled blood pressure, what's the problem related to anesthetist? These acute complications can occur. This is number one. And number two, the because the myocard this cerebral autoregulation curve will be shifted to the right. So patient may become, if you give the patient hypotensive anesthesia, or if the patient remain hypotensive for a long time, this can cause anoxia. It can cause ischemia because the normal blood pressure reading for example, 60 to 160 for brain or 80 to 180 for kidneys, they are shifted to the right. Maybe 60 is hypoxic, sorry, 60 is ischemic, or maybe 80 is ischemic for these patients. So because the chronic hypertension effect you should be thinking. So again, I am repeating hypertension, its pathophysiology. Causes of secondary hypertension, you can revise acromegaly and pheochromocytoma. I'm not wasting my time there. You can read about it. Because again, I'm repeating, this is whatever I'm trying to do is a conceptual class. You are not babies, you know everything. You just have to align how to understand the question and how to answer. Because if you don't understand these things, you will just try to reproduce the pages and you will miss. You will not be able to answer till the time you don't understand what exactly they want you to tell. Okay. So this is how relevant you will make your answer. So now we are coming back to the scenario. If they have told you there is a hypertensive patient coming for any procedure, so you will be thinking about these things. Hypertensive patients, microvascular and macrovascular complications, the medication patient is taking, and the end organ damage already has been done or is patient can have. So any hypertensive patient can have increased risk of this myocardial advanced cardiac events, the what is called as MACE. Okay, so you can use these words that there will be more chances of cardiac. If you this is a little difficult word, you can only say increased chances of myocardial, sorry, cardiac mortality and morbidity. Patient can go into
मेजर
pulmonary.
सर सर ये है मेजर एडवर्स कार्डियक इफेक्ट मेस
Yes, yes, major. What I have said?
मेजर सर
No, no.
आपने
What I
कहा कि
said? I said
मायोकार्डियल
myocardial. Okay, okay. Thank you, thank you. So anyways, so MACE is major adverse cardiac effects events. Okay, so you can look into it. So these are the things you have to. And one more thing you will tell in hypertensive patient, you can make your answer of 30. As I mentioned yesterday, if you have to make your answer in 30 to 60 seconds. This because whenever they are asking you hypertension in scenario, you don't have more time to tell a big story. You have to squeeze your answer in 30 to 60 seconds. So that is the only way you can make. The patient will have, I have to look into the cause of hypertension, pathophysiology, medications and their side effects and relevance to anesthesia, and microvascular and macrovascular complications resulting in end organ damage. So my focus will be on the basis of history, examination and investigation. I will be look into it, any complication. So if they want to ask you some details, they will ask you. But if you understand this thing, so you can tell simple way. If you want to see the retinopathy, you will ask about any visual field effects, and then you will refer. You will be saying, I will do fundoscopy. No, it's not your job. You will just identify and you will say, I will involve the ophthalmologist and we will be doing endoscopy, sorry, retinoscopy, and these are the findings. This is the smart answer, or this is the answer of a upcoming consultant. You will be say, I will do fundoscopy. This is a crap answer. I'm sorry. This is not a answer of anesthesia consultant. Okay. So you will speak out like that. And these are the findings. There will be new vascularization. There will be dot hemorrhage, blot hemorrhage, or whatever. You can tell about it. Similarly, if you want to, they can ask you further about nephropathy. You can tell that you on the urine RE, you will find albuminuria, and you will find this corticomedullary differentiation loss. So things like that you can tell. Okay. Similarly, for as I told you, for stroke, TIA, carotid Doppler, CT scan, CT angio. For heart, we have discussed ECG and echo and thallium scan and ambulatory blood pressure, Holter. These are the things you should be looking. So you can expand your answer. And I can guarantee you, if they have to ask the details about hypertension, they will tell you, they will ask you. But your answer should finish, or your answer should include these things which I have told you. Microvascular and macrovascular complication related to hypertension, as I told you. Okay. So I hope you understand. So if they want to ask in details, then you can, and then they will come into the each and every step. You will ask about the control, and you will tell that I not one reading will not tell you, because one reading maybe because of white coat hypertension, because of anxiety. So what you will tell, that either if you have any doubt, if there are swings of blood pressure, we can have ambulatory blood pressure, or you can say we will look into the consideration the preoperative ward readings. So ward readings, average of that will tell you what is the baseline blood pressure. Okay, not one reading. So people actually, this is one of the favorite thing for any non-interested anesthetist to cancel the case. So actually, only one reading in pre-op period, or in when the patient is brought to the operation theater, and you there is one increased reading. This is not the reason to cancel the case, but because this is the famous way to cancel a case, so we think that this is the reason of cancellation of case. I'm sorry, this is not the reason of cancellation of a case. You have to look into consideration the baseline readings, not single reading. Okay, so this is how. And then what will be the next, you can tell in the same way, that you will be monitoring maybe 5 lead ECG. This is one thing you can say. You can monitor if there is problem. You can have T, you can have cardiac output monitoring, you can have intra-arterial blood pressure monitoring, in addition to standard 1 and standard 2. So your answer will be, because patient has this problem, so I will be, in addition to standard 1 and standard 2 monitoring, maybe I will be keeping the 5 lead ECG, and I will be looking for arrhythmias and ischemia. I can have, if the facility is there, T can help, because it can identify the segmental wall motion abnormalities, and I can pick any problems. Cardiac output monitoring, intra-arterial blood pressure monitoring, and you can also say point of care testing with reference to maybe ABGs, okay, and cardiac enzymes if needed. If needed. I'm not saying that you start your answer, sir, I have a cardiac patient, so I will do cardiac enzyme because Dr. Zishan had told me. No, please don't. I'm apologizing to you. So you have to tell in an order that these are the possible things which you can have. Okay. So this is for intraoperative monitoring. Swings, intra-arterial blood pressure for swings of blood pressure, cardiac output monitoring, as I have told you, T and fly blind ECG. This is the sequence of
Sir,
events. Yes,
sir, do we also mention the Foley's catheter
very
is
good.
required?
Yes, to monitor the fluid status. Very good. Police catheter and also focus, as I told you,
Right, sir.
fluid
Sir,
responsiveness, cardiac output,
pulmonary artery catheter, sir.
pulmonary artery catheter or CVP. Then you can also tell about pulmonary. But I'm just telling you, listen, use these things, like I have told you, keep these things in your mind. Okay. Not normal patient will need CVP or pulmonary artery catheter. Okay. So you can just say that if you can use the brain and you can tell gradually. Usual common thing you can tell is intra-arterial blood pressure monitoring or 5 lead ECG. This is the commonest thing. And then
Sir,
you can explain.
you also missed the pulse oximetry.
No, that is in standard 1 and 2.
Okay, okay, right, sir.
Standard 1 and 2, and I'm not focusing right now. So pulse oximeter, standard 1 is the presence of anesthetist, and standard 2 is pulse oximeter, ECG, anti-idle CO2, okay, temperature monitoring, blood pressure, non-invasive blood pressure. These are standard 1 and standard 2. These are, that's what I'm telling you. In addition to standard 1 and standard 2 monitoring, I need these things. Yes, you nicely you tell me. So the more then if according to the scenario, if patient has a risk of heart blocks or anything, maybe temporary cardiac pacemaking. Okay. So these are maximum thing you can have. And by the way, if you have a very high risk patient, then the last resort may be at Santa ECMO. Okay. So what these are the things, ECMO or this intra-aortic balloon pump. Okay. So or bypass. These are the things which are coming at the end. But these are sequence you should be knowing. Okay, patient has hypertension, maybe uncontrolled. So I need there are swings of blood pressure. So in addition to standard 1, 2 monitoring, we should have intra-arterial blood pressure monitoring. Okay, the patient is having need for inotropes, vasopressors. So maybe I need central CVP. Okay, the patient can have problem in the fluid status. If you have the facility of pulmonary artery catheter, maybe I need it, or I will use cardiac output monitoring for the same purpose. Okay. So I hope you understand what you need to do with reference to, and actually, if you understand these things, Same thing will be coming in ischemic heart disease. Same thing will be coming in valvular heart disease. There is nothing left. If you understand the sequence of events which you need to do in any cardiovascular patient, same things will be there. Same intra-arterial blood pressure monitoring, same cardiac output monitor, same pulmonary artery catheter, same use of focus, same use of T, same use of this as corrected by with reference to Foley's, or with reference to, so anything which is leading to overload, sinus rhythm, heart rate, blood pressure. These are the things. Okay. So these are the things which you should be, because we have covered most of the troubleshooting of a cardiac patient. So actually, we have covered the hard part. So any comments, Ahmed? Anything you want to add? Anyone else want to speak out, or only all of you are just listeners? Wakar, where are you sitting? Are you sitting on eggs? You want to hatch them? Why you are not speaking? You have a viva, I think. Are you alive, Wakar? Okay.
जी सर जी.
Okay, you don't want to speak out anything?
Sir, it's Maghrib time here.
Okay, no problem. Take your time. You can pray. Okay. So so in this way you can cover some of the points. So as I told you, that if they are asking for any surgery hypertensive patient in which there is need of hypotensive anesthesia, you have to be careful. Okay, you have to be careful with hypotensive anesthesia. Okay, with reference to induction of anesthesia, you have to be careful. Okay, so if any condition in which rapid sequence induction is needed, it is better if possible modified rapid sequence induction, because rapid sequence induction may cause sudden fall in blood pressure. So modified rapid sequence induction will be a better choice. Okay, any medication which is causing significant change in blood pressure or heart rate, like for example sux, it can cause bradycardia. And for example, if you are using any medication which is causing histamine release, okay, so you consider all the medication which are releasing histamine, like atracurium, like pancuronium, or like morphine. So these things can have to be used carefully. Of course, opioid based anesthesia is also needed in any cardiac patient, because it's good, because you have to blunt the adrenergic response. So but you have to then of course, as I mentioned to you, do anyone knows about what is mac bar? Ahmed, you know about it?
Sir, 90%, sir.
No. What is bar?
Sir, sorry, sir, I forget, sir.
Bar is blunt adrenergic response.
Okay,
Okay,
okay, right, sir,
so it is
right.
around
Yes,
2
sir.
to 3 mac.
Sir, it is the same thing to blunt the laryngoscopy response.
Yes, this is the same thing. It is Mac
Okay,
bar.
sir.
The technical terminology is Mac bar. So because point 3 Mac is Mac awake, okay,
Yes, sir.
and usually you need 2 to 3 Mac for blunting adrenergic response. Okay, so this is the concept. So how you can do it? You can use short laryngoscopy. Okay, you
Yes, sir.
can
Less than
use,
15 seconds.
yes, you can use video laryngoscopy if you are expert video. If you want to spare the time, then you can have lidocaine either IV or spray. Okay, then you should be knowing what you are doing. If you are giving spray, it can cause laryngospasm itself. It can cause, it can predispose to aspiration. Okay, so whenever you are using the spray, and then another question, possible questions about spray, they you should be knowing that 4% or 10% means 40 milligram to 100 milligram per ml. And usually it is different in different manufacturers, but maybe around 10 spray is equal to 1 ml. So One spray is 4 to 10 milligram, and the dose is around 9 milligram per kg. So these are the things which you should be knowing about spray. Then you can have beta blockers, short acting beta blockers. You can have opioids. Again, better to have like any, like you can use remifentanil, you can use fentanyl, or you can use morphine or like nalbuphine, whatever you have.
Alfentanil.
Yes, try to use the tell the name of medications if they ask. Okay, if they don't ask, don't try to impress, and actually you don't have too much time, so don't waste your time. You can say we can use beta blockers, opioids, lidocaine spray, short laryngoscopy time. Okay, and monitoring the blood pressures accurately by intraarterial blood pressure. Maybe you can have awake arterial line. Okay, so these are the common things which you can need, you may need. And actually good amount of muscle relaxation. If you are not giving proper muscle relaxation, patient will fight and it can have more swings of blood pressure. Not only actually the and the same thing will be needed if you have any ophthalmologic surgery, because it will affect the IOP, or any neurosurgical patient because it will affect the ICP. So these are the
It
things, these are the
also,
common.
sir, secure the correct size ETT with tape, not with bandages.
Yes, what's the problem with bandage?
Sir, it can increase the ICP and also the blood pressure ultimately.
ICP and also cerebral perfusion. Okay,
Yeah,
like in
right, sir.
more correct answer is cerebral perfusion will
Pressure.
be changed. So these are things which are interrelated. Okay, so okay. So what else? And actually, we are covering, we have covered at the moment hypertension, but actually these are the common thing for ischemic heart disease, for valvular heart disease, for a heart failure even. Okay, we will just discuss in detail a special needs what we can do. In place of propofol, we can have etomidate. So then they can ask you what is the problem with etomidate. So you have to tell about adrenal suppression and myoclonus. Okay, and it is relatively slow, not as fast as thiopentone. So thiopentone, then propofol, then etomidate for with reference to speed. What is the technical word for it? Brain, arm to brain circulation time. Arm to brain circulation time. Okay. So ketamine is also there in hemodynamically unstable patient, but actually ketamine, is in small doses. Okay, it's better to use ketamine in small doses as a cocktail. Okay, if you make a cocktail with the benzodiazepine, opioids, okay, and you use this, as I mentioned to you, modified rapid sequence induction, so that will help. And among the opioids, like tramadol can cause tachycardia, and pethidine will also can also cause, because it has acetylcholine like effect, sorry, anticholinergic effect, so it can cause tachycardia. Okay, and other name of pethidine is mepridine. So these are the things. Similarly, fluid management, judicious fluid management, you can tell, or goal directed. You can use this word, goal directed, and you can monitor through cardiac output monitor, Foley's, in this AIPP waveform. Okay, and also this through T monitoring. Okay, or this focus. All these things you can monitor the fluid status, and you remember one thing: you don't need to overload, but also you have to maintain the volume. Okay, because if you don't are not able to maintain the volume, even that is a problem. Doesn't mean that you have fear. So then you can use colloids instead of crystalloids. Okay, so if you have a good colloid like albumin, that will be a better choice as compared to crystalloids. Yes, if you are fearing of the colloids related problem with the like bleeding and renal failure and anaphylaxis, that's something else. But you can tell that if albumin, it's a safe option. It's a relatively safer option. So you can use this thing. Then a very good multimodal analgesia. Okay, multimodal analgesia. So with paracetamol and said if there is no other contraindication, then opiates, okay, local infiltration or any blocks, okay, low dose ketamine as I told you, Presidex, dexmedetomidine, okay, and also preemptive analgesia with either gabapentin and with this PCM and NSAID. So this is the simple plan for multimodal analgesia. Okay, so you can the same thing you will tell here, whether it is because the purpose is myocardial oxygen demand versus supply. Okay, so because ultimately even hypertension can cause the adverse cardiac effects. The maybe the main source will be this one, demand versus supply. Okay, so this will be correlation will be there. Okay, then similarly the same thing which you will be considering when you are anesthetizing the patient, same thing will be in the recovery. Okay, so the same thing new stigmine what glycopyrrolate can have more cardiovascular instability if you have using rocuronium. So Sugamadex is a better choice, but remember there are cases of Sugamadex related bradycardia. The mechanism is unknown, where there are chances of Sugamadex related bradycardia. Okay, so this is something you should be considering whenever you are doing it. And then another important point will be recovery to as a day case. They can ask you, can be done with as a day case or admission to ward or HDU or ICU. You should be knowing what will be the reason of HDU admission and what will be the problems if you want to do it as day case. So again, the same things answer will be starting from the pre-op, that these are the things we should be knowing or you should be considering for any cardiovascular patient, especially we have discussed hypertension, and then we will peep into now the next things. Okay, so I think if we will try to cover if anything miss. Now I will just give few words about this valvular heart disease. Okay, usually in young female adults, usually the scenario which they ask is my MS in like maybe in a female or usually they take as obstetric patient. Okay, and then they will make a scenario of a patient with the mitral stenosis with obstetric in an obstetric patient coming for C-section. So this is a common scenario they will ask. Or if they are taking in old age, maybe they are taking aortic stenosis in old age. So usually this is the common thing. But of course they can make anything. Usually whenever you are thinking about valvular heart disease, you should be knowing some words about the etiology. So etiology may be degenerative or congenital, or usually it is rheumatic. Okay, so rheumatic fever, so leading to this valvular heart disease. So this is one thing. Then, as I told you again, how much end organ damage. So we will just simply identify what is the problem in various valvular heart disease. What happens usually? What will happen? Whether it is mitral stenosis or aortic stenosis, ultimately what will happen? It will affect the pulmonary vasculature and it will result in pulmonary hypertension. When pulmonary hypertension will occur, it will affect the right heart because right heart is not tuned for high pressures. So it will cause congestive heart failure. And mitral stenosis, the door is not opening properly. So there is a stasis, there is chances of development of clot. And then because low volume is coming, so heart has to work more, contractility need to be increased to maintain the cardiac output. And because the volume status is very like heart is filled, so in either side, now the problem is that some people say use this word as a very wrong, tight and slow, fast and loose. This is written in the books. Okay, so I'm sorry, please don't use it, overuse it, because if you, for example, how I can explain, you will say I will increase the SVR. Just tell me one thing, in a diseased heart, if you increase the SVR, is it good? No. Better answer is that I will maintain the SVR and I will not let it go down. Okay. So this is a better answer rather than I will increase the SVR. No, because SVR, if it is more, it even does, it is not good. It is not too good for the heart. Similarly, if the patient is hypovolemic, yes, we say that we have to maintain the preload, and if there is a decrease in SVR and there is there is decreased preload, so patient will not be able to maintain. Okay, and if you give increased blood volume, it can also cause pulmonary edema. Okay, so, but doesn't mean that you will make it SVR too high. Similarly, they say that make the heart rate low normal, so around 60 to 80 rather than 80 to 100. So 60 to 70 or 60 to 80. So the answer is that you will not let the patient having tachycardia. Okay, because if the bradycardia is the heart rate is too low, even then the cardiac output will not be, because SVR, and the reason is that the stroke volume is fixed. So if just tell me one thing, your heart rate became 40, will it be able to maintain the cardiac output? The answer is no. So I hope you understand. So you will tell that we will maintain the SVR and don't let it go down. We will maintain the heart rate and not let it go up. This is the answer. Okay. And then again, the third thing which we see is rhythm, because these patients tend to have AF. And why there is AF usually? Because usually the ejection phase, when the mitral valve open, passive ejection is very good. Okay. But if the door between the left atrium and left ventricle is narrow, the normal ejection will be decreased and atrial kick will become more and more important. Okay, normally maybe it is, if it is 10 to 20% involved, now it is more than 40% of cardiac output is dependent on this atrial kick. So when atria are in trouble, they can go in atrial fibrillation. Okay, so then if atrial fibrillation occurs, then cardiac output patient will not be able to maintain, because patient is dependent on the atrial kick. So this is the concept of what happens. And similarly, whenever the patient has clot, so then the problems of anticoagulants come into play. Okay. So, and then remember one thing, whenever there is a stenotic lesion, they will ask you the valve size. Okay. And then pressure gradient, transvalvular pressure gradient. And then there may be gradually, there will be regurgitation. So it will become a combined mitral stenosis and mitral regurgitation in long standing, untreated. So then it became like a valve is in between. So it's not able to close at all. So even during there is regurgitation. During diastole, the volume is going back. Okay. So this is how you have to understand, and you have to act upon it. So whatever scenario they are asking, you should be knowing that it is mitral stenosis. So I have to look into that goals. Preoperatively, I will take a history, examination, and echo, and we will be looking into it. We can have, if like in pregnant patient, you will avoid chest X-ray, but maybe you need to have chest X-ray. Otherwise, ECG, echo, and you will look into consideration these things: chamber size, chamber clot, this valve size, valve transvalvular pressure gradient, and regurgitant fraction. This is the sequence of events. And we did not, because I told you that we will discuss with valvular heart disease about echo. So hypertension, even here, there are two different types of failure. One is diastolic failure and one is systolic failure. Okay. So systolic failure occurs usually at the end with decrease in ejection fraction. So ejection fraction will remain normal even if the heart is not good, because initially there is diastolic dysfunction. What is the result is concentric hypertrophy, concentric hypertrophy. And what is happening? That heart is not able to relax. The Frank Starling law says that the more stretch, the more contractility. Okay. But what is happening? Because the valve is thick, so the contractility is decreased. So if there is, the initial relaxation is decreased, the patient is not able to receive blood. Heart is not able to receive proper blood. So if it is not properly receiving the blood, the ejection fraction, because ejection fraction is the part of end diastolic pressure which is throughout. Okay. And and systolic volume is the volume which is there at the end of systole. Okay, so the thing is that the difference between them is a stroke volume, and the fraction is the ejection fraction. So, for example, usually heart is receiving and diastolic volume is 100, and out of that, for example, 70 ml is ejected, so ejection fraction is 70%, for example. Okay, now what is happening? The because of impaired relaxation, heart is only receiving, for example, 50. So now, if out of 50, patient is sending, for example, 40. So the ejection fraction is 80%, for example. But is it good? It's not good. Because so good ejection fraction number is not an accurate sign. So ejection fraction, if it is low, it's significant. If ejection fraction is normal, it's not significant at all. It does not mean the heart is good. You have to look into other parameters. So diastolic failure is very important. And that I have told you here, this is called as E over A ratio. Usually E over A ratio is in positive number because ejection is more than atrial contraction. So usually it is maintained. Okay. But gradually when the portion of A is increasing, this A over A ratio is decreased. Okay. So that is the concept of E over A ratio. So the same question they will ask you. So rest of the things which we have discussed are the same. Something extra if you have a scenario in a female, 35-year female with the mitral stenosis and coming for C-section. Okay. So majority of things will be the same. Here, what extra things you are expecting with reference to uterine conics. Okay, because the oxytocin is a dangerous thing. So you will try to avoid oxytocin. If you need to give, you will give in infusion in low dose rather than a bolus. Okay, so this is the thing which you should be considering. And if they are talking about, for example, epidural, so what is the important thing you need to tell or you should be considering is anticoagulation. Okay, so anticoagulation, the correlation between this one and another thing is that you will not use as a sole agent because for that you need to give more medication. So it became a dangerous thing if you have a tight mitral stenosis, for example. But if it is like mild, you can use epidurals. Okay, rather it will decrease the stress. Okay, so actually it is helpful. But again, you have to consider about anticoagulation. So if they are asking you about this thing, choice of anesthesia, so epidural, you can say that I can do an epidural, but these are the consideration which you have to tell. Okay, so rest of the things are the same preoperative evaluation, risk stratification, involvement of how much heart is damaged, how much you will see echo, you will see the results, you will see the valve size and everything. And then one important thing will be maybe there are patients who are operated. Okay, so operated cases, actually there are two types, whether they are tissue valve or they are mechanical valve. Okay, so tissue valve maybe are having less dependent on anticoagulation, but mechanical valve they are totally dependent. So for that, the will be on anticoagulation. So the concept of bridging will come. Okay, bridging of anticoagulants. So here you have to tell about bridging, and usually of course, they can ask you about new medications, but the traditionally is that if you are taking long acting like Laxane, you will convert into heparin, okay, and you will stop 4 hours before, okay. And if you are using this heparin, sorry, Claxane, because here it will be therapeutic dose, so it will be 24 hours for the therapeutic dose. You need to stop Claxane 24 hours if you are taking therapeutic dose. And if you are taking prophylactic, you can stop 12 hours before. So these are the things which you have to consider. If they have asked you, rest of the things, believe me, are the same. And then again, one thing extra is physiological, pharmacological, and anatomical changes of pregnancy affecting the cardiovascular system. So there is increased blood volume. Okay, there is dilutional anemia. There is so already cardiac output is more, blood volume is more. So mitral stenosis patient can have a like collapse. So you have to keep these things in your consideration. Like the general rule is that 1 + 1 is not 2. 1 + 1 is more than 2. Okay, so it may be 1 + 1 is equal to 3. Means a separate mitral stenosis and separate pregnant patient, and now they are combined. So the morbidity will increase and the chances of complications will increase. So you will say the cause of pregnancy, cardiovascular changes. So you can just explain these things. Okay, already hypercoagulable state, and here there is clot as well, or there are more chances. So the role of anticoagulation, and then you can read in details. Even maybe patient can be taking less than 5 milligram of warfarin. Usually warfarin is a teratogenic medication, but usually you will find recommendation for use of warfarin during pregnancy. So you will find a format about it. Okay. Usually the common things I have told you. The rest of the things are the same intraarterial blood pressure monitoring and the intraoperative monitoring which we have told. Same use of blunting of stress response. Okay. And if it is severe, you cannot use blindly spinal, because the spinal can have sudden change in hemodynamic and it can decompensate the patient. I have discussed about multimodal analgesia is the same. If you understand, you have to tell the same things. Okay, you can, if you are not using epidural, in this scenario of cesarean section, you can tell about tab block. Even carefully, you can give tab block even if the patient is taking anticoagulants. You can say that I will give carefully, or even when the surgeon is closing, they can give under vision. Especially not in C-section, in any surgery in which they are doing laparoscopically. So they can give under when they are bringing out the port, they can inject. So tab block, you can say, tell about tab block. So these are the things which are commonly asked with reference to because we will discuss maybe aortic stenosis and things related to it. The common things are the same, and elderly physiology will be there if it is an elderly patient. Okay, so TURP patient with aortic stenosis coming, elderly patient with the aortic stenosis coming for TURP. This can be another scenario we can discuss. The rest of the things will be the same. Here we are considering the physiological, pharmacological, and anatomical changes related to pregnancy. There will be the physiological, pharmacological, and anatomical changes because of elderly patient. So you should be thinking about all the challenges which you can have in an elderly patient. Okay, and the words will be the same. That again, as I told you, make a answer of 30 to 60 seconds for both elderly patient and pregnant patient in such scenarios, because actually they are not asking you the changes in elderly. So you cannot overdo. You just have to tell them that these are the things which can occur in an elderly patient, or these are the things which can occur in an obstetric patient. But that's not the end of the world. You have to tell about because they will be asking you about cesarean section as well. They will be asking you about, if they are asking TURP, so they are asking about TURP as well. So you in 5 minutes, how much they will ask? Usually scenario will be like this. Okay. Same concept of HDU, same concept of ICU, same concept of so these are the things we should be considering. Okay, so we have covered some of important points. So any question up till now? please, if anyone wants to comment anything or anything you want to add. Yes, Ahmed. Any comments from anyone? Okay. So let's see what they have made with AI. What AI is telling. I don't think so. I was just looking into it. I have told you all the majority of the things I have explained to you in detail. I don't think so. You will find very important things here. Just a second, please. Okay, so few things more. So, what complications? Because usually, whenever they are asking this question, they can ask few things sidewise. Okay, like for example, they can ask in if a patient that the patient became hemodynamically unstable. Okay, with fast AFib. So, what will you do? So, your answer will be again the same concept of airway, breathing, circulation. Okay, and what will you be doing here? You will be, if the patient is hemodynamically unstable, you will shock DC cardioversion. Okay. Or if, for example, if it is hemodynamically stable, then you will go for rate control or rhythm control through beta blocker or amiodarone. Usually, you will also try to correct any correctable electrolytes, like maybe you need to give calcium or you need to optimize potassium levels, or maybe you need to give magnesium. So these are the things which you can do. Okay, for atrial fibrillation. And of course, as I told you, that this patient can have embolism. Okay, so chamber clot is to be ruled out. Similarly, they can ask you another question with reference to hypertension or anything, either the terminology which Ahmed discussed, Ahmed spoke out with reference to malignant hypertension or MI. Okay, so MI can occur. So what will you do? Again, the same approach: airway, breathing, circulation. Stop the surgeon. You will just try to give 100% oxygen. You will, if hemodynamic, because MI presentation may be arrhythmias, okay, maybe hypotension or failure, okay, or like patient can become in shock. Intraoperatively, you will find these things. You will not say the patient is saying that I have pain. So usually this like there will be sweating, there will be the patient can have hypertension or hypotension. Hypertension can precipitate MI, or hypertension can cause MI. And again, after MI, there may be hypotension. Like initially spike of hypertension and then gradually hypotension. Okay. So what you need to do immediately, cardiology referral. You will try to, if possible, surgically possible, you will try to stop the surgery. Maybe they can do packing. You can have 12-lead ECG. You can send the enzymes. You will look into the consideration cardiology, what the cardiology can do, because according to the scenario, if you have arrhythmias, you will treat the arrhythmias. Patient might need to have this pacemaker, for example. Okay, patient might need this ECMO or bypass perfusionist, because whenever there is MI, all these things can be required. Of course, heparin will be difficult to give, because if you give thrombolytic therapy, patient can start having bleeding. So according to the scenario, we will say that if the patient is surgically stabilized, maybe they can consider to shift the patient to cath lab. Okay, so you will say that cardiology will be consulted, and further management, these are the different options will be there according to the patient scenario. Okay, of course, if a major surgery is going on and you have MI, you cannot shift the patient directly. So you will just try to do the risk stratification with factors avoiding the myocardial oxygen demand. If your patient is hypertensive, you might need to give some vasopressors or inotrope. You can pass CVP, or you can start having cardiac output monitoring, or you start can, if the patient does not have arterial line, you will take the arterial line. So these are the things you have to answer them tactfully. The basic thing is that airway, breathing, circulation. Then you will come into monitoring. you will increase the oxygen. You will call the cardiology. You will do the 12 lead ECG. So this is how you will proceed to give this answer. So arrhythmias, they can ask you for arrhythmias, any arrhythmias. No, not only this AFib, any arrhythmias. If anything in which the this vagal maneuvers are recommended, you will just say about vagal maneuvers. Otherwise, bradycardia is arrhythmia, tachycardia is arrhythmia. So all these things you will just consider and act accordingly. You will correct the anesthetic factors. You will correct any correctable things like electrolytes or anything which you can correct. And then according to whether it is hemodynamically unstable or stable, whether it is shockable or non-shockable, whether it is receiving a patient, if a patient is having, for example, VT, so you will tell about lidocaine, and if it is unstable, you will go for shock. If it is torsades, you will tell about magnesium. Okay, so pacing will be maybe required, amiodarone may be required, so or any other common antiarrhythmic. So this is how you can answer this question. So whenever they are discussing about hypertension or ischemic heart disease, they can ask you about this thing. So with reference to valvular heart disease, I think these are the common thing. Another important thing which I think I did is the prevention of endocarditis, bacterial endocarditis. Okay, so you might need to give some antibiotics. Okay, and also uh, whether it is repaired or unrepaired, something like that. I don't remember. So you should be knowing in which conditions, which surgeries you need to give prevention of bacterial endocarditis. So you know I've been exhausted. So none of you is speaking. So anything you want to add? Because ischemic heart disease, rest of the things are the same. Only important things are cardiac enzymes. Okay, so you should be knowing which cardiac enzymes increase. Okay, I don't remember exactly, but CPK, CKMB, and about TROP-T and TROP-I. TROP-T and TROP-I are more sensitive, but sometimes there are certain other condition in which TROP-T can also increase. So similarly, you should be knowing their peak and trough, crust and trough. You should be knowing when they start to increase, when they develop the peak, and when they become zero. So only accordingly you will come to know that what sort of angina it is, and whether there is MI. Of course, ECG is there, and the rest of the investigation which you need to do further, you can refer. Ischemic heart disease, they can ask you these things: what is angina? What are different types of angina? Okay, and then MI I have discussed with you. Okay, the cardiac enzymes you should be knowing. And the cardiac involvement is the same. You should be knowing what are the corresponding leads, like what are inferior leads like 2, 3 AVF, and what are like lateral leads, 1 AVL, V5, V6, and anterior leads, V1, V2, V3, V4, and this septal leads. Okay, so what are different happenings which can occur in MI, unstable angina. Okay, one more important thing I will discuss with you because I have not discussed up till now. So these are very important thing. What is called as active cardiac condition? Active cardiac conditions, or in some books you will find major cardiac predictors. Okay, so they are actually acute or recent MI. Okay, so recent MI 30 days and acute MI 7 days. So this is one. Unstable angina. Okay, unstable angina, and you classify according to Canadian class. So it is 3 and 4. It is written like this: 1, 3, 3, 4 Canadian. Or there is a D, what you say, D,
Decompensated heart failure, sir.
decompensated heart failure. Okay, decompensated heart failure with the New York Heart Association class 3 and
Class
4.
4.
3 and
Yes,
4.
sir.
Okay, and then severe arrhythmias. Severe arrhythmias including like unstable
High
VT,
degree heart
unstable, yeah, bradycardia,
disease.
newly diagnosed bradycardias. So you can have a list. So severe arrhythmias and severe valvular heart disease. Okay, so these are active cardiac conditions. These are active cardiac conditions. So this is the first step. So this is the first step. So if you have a no cardiac patient for non-cardiac surgery, the first step for you to look into is there any active cardiac condition? This is number one. And then second thing will be the urgency of surgery. Okay. If the surgery is urgent, you just, how do we operate 35% injection for pelvic surgery? Yeah, we will discuss. Just wait for a while. The same things. Actually, I have discussed any patient with failure, you will have the same thing which I have discussed. Intra-arterial blood pressure, the use of etomidate, avoidance of the medication which release histamine. I have discussed everything. The use of POCUS, the use of focused echo, the use of 5-lead ECG, maybe cardiology can be on board. Maybe you need a pacemaker. Maybe you need. I think you have joined late, Dr. Humera. That's why you do. So urgency of surgery. Okay. So active cardiac condition and urgency means that surgery is emergent or urgent or elective or planned. So these are actually emergent is usually within minutes. Okay. And urgent is usually within hours. And they are written simultaneously as urgent or emergent. It's almost the same. So we consider, but there is a minor difference. So if the surgery has to be done in minutes, it's real emergency, or usually we say E1, and E2 is within hours. So this is also emergency, but it is like you can say that it can be delayed for few hours. It's like that. And then similarly, there is elective. In elective, there is pure elective, like the which has no time. You can delay it for months. Okay, and the surgery which has to be done within few weeks. So that is planned. Usually, traditionally, elective surgeries are only cosmetic surgery, joint replacement. These are only bariatric surgeries. These are only elective surgeries. Otherwise, usually, like for example, if they have written cholecystectomy now actually nowadays it's being done in acute. They are doing acutely. Okay, so now actually it has become like emergency, but usually it is a planned surgery. Okay, planned surgery can be, for example, this. TURP. You can just plan and you can do. But if it becomes patient becomes urine is blocked, then it become emergency. Okay. Similarly, hernia surgery you can plan, but if hernia become strangulated, it will become emergency. Okay. So you should be knowing any surgery. You should be knowing what is the urgency of surgery, and you there is a list from American Heart Association or European Society of Cardiology that what are the various urgency of surgery. Okay, so this is, and then the another important thing will be the physical activity what we consider as mets, metabolic equivalents. Okay, so for anesthesia it should be more than 4, or
Yes,
there
sir.
is
Also known as the Duke Activity Index. You know, sir?
yes, Luke activity index, very good. Okay, and if patient only when patient cannot move, so you cannot assess the physical activity. Okay, then this is a challenge. Like for example, if a patient has a knee problem or a hip problem or any physical disability in which you are not able to evaluate the physical activity. Okay, patient is bedridden now, you don't know whether the what is the functional class, so then you have to go for like so if one is the active cardiac condition, one is the physical activity meds, one is the urgency of surgery, and then you will go for clinical risk factors. Clinical risk factors, or you can say that this Lee revised cardiac risk index, they also say, or intermediate predictors. Okay, so intermediate predictors are like you can define like that. Here there is acute or recent MI, there it is old MI. There it is unstable angina, there is a stable angina. Okay, there is decompensated heart failure in clinical risk factor, it is compensated heart failure. Okay, then there are three more things which are there. One is CVA, one is CRF, and one is diabetes mellitus insulin dependent. CVA, CRF with creatinine more than 2 milligram, or if you find it in micromole, so it will be 176 micromole. Okay, it's like that. So it is multiplied by 88. You have to multiply this milligram per dl to convert into micromole per liter. Okay. And insulin dependent diabetes mellitus. So according to the number of clinical risk factors and physical activity, they will do the stress testing. Okay. So the stress testing will be either this thallium scan or stress echo.
Dopamine stress echo.
Yes. Okay. So this is how you will evaluate the patient. So whenever, even now, how will you chalk out these things? Any of these things together according to the physical activity or according to the urgency of the surgery and according to the risk factor, you will decide whether you have to. There is a chart for it. If you have one or two risk factor or you have more than two risk factors alongside these things, so you will be doing different tests. You can just cram how it is written. Okay. So, but usually this is the way you will look into consideration. How will you proceed? Okay. So whether the patient needs further evaluation depends. First thing is urgency of surgery. If you have an urgent surgery or emergent surgery which you cannot delay at all, even if there is active cardiac condition, you will take the high risk consent, you will book an ICU, you will explain to the family, and you will proceed. You cannot delay. Like, yeah, like I have seen patient with acute this GI bleeding, and some of the doctors they advise echo. Can you believe this? If the patient has acute GI bleeding, patient will die before echo is done. Okay, so the patient has fetal distress, and patient had mitral stenosis, and you send the patient for echo. How will I anesthetize? No, I'm sorry. Okay. So active cardiac conditions, only you will proceed when there is emergent surgery or urgent surgery, okay, which you cannot delay or which will not change the management. And even if you are referring the patient for cardiac evaluation, you should be knowing why you want. So ultimately, is there any correctable or thing? Like, for example, if the patient is having heart failure, maybe some of the anti-heart failure medication will improve the cardiac outcome and they will proceed. Or maybe any surgery which can be delayed, maybe they will do the stenting, maybe they will do the cardiac surgery for valves. So anything like that. Maybe if the patient has arrhythmias, maybe they will put pacemakers, okay? Or they will do EP study, electrophysiological study, and ablation. So I forgot to tell you when I was starting the discussion. Okay. So for arrhythmias, this is a sequence of event. Pacemaker or electrophysiological study with ablation of the rhythmogenic point. Okay. Or patient might need to put AICD. Or now again, I told you that there was advancement. Maybe patient are put with left ventricular assist devices or anything like that, or artificial heart even. Okay. So according to the scenario, you will expand your answer. So this is how you will handle any scenario in cardiac patients. So now the only few things are left with reference to heart failure. So of course you have to identify whether it is acute heart failure or chronic heart failure, whether it is right side heart failure or left sided heart failure, whether it is low cardiac output heart failure or high cardiac output heart failure. Okay. And then what is the pathology? You can you improve a little bit? Like for example, if patient has pulmonary hypertension, maybe some treatment of pulmonary hypertension with sildenafil or any pulmonary vasodilator, use of nitric oxide can improve it. Okay. If you have a patient with the heart failure, you need to give some diuretics. You need to give some AC inhibitors. It will improve the function. And again, these things will be according to the time you have with the patient. So make a habit. I will discuss with the surgeon how much time we have. Okay. You make a habit of answering this one line answer all for almost every surgery. What is their plan? How will they be doing? Okay. So I have discussed in detail about the types of surgery and surgical concerns in the fold you can find in the YouTube discussion, scenario based. So in scenario based, I have discussed. So we will try to cover as much as possible. So like cyanotic heart disease, usually actually they either heart tetralogy of Fallot or Eisenmenger syndrome, the basic theory you should be knowing that it is the balance between the SVR versus pulmonary vascular resistance. Okay. If there is decrease in SVR and there is increase in PVR, there will be right to left shunt and there will be hypoxia. Okay. So you have to avoid the factors which will decrease the SVR or increase the PVR. Okay. So this is the basic principle. Otherwise, they will go into detail. I don't think so. They ask too much details about cyanotic heart disease these hour, because this is a cardiac anesthesia specialty. But you should be knowing these are the things which you should be knowing, that whether it is right to left or left to right. Okay. And because sometimes this PDA, anything which is closing the PDA, sometimes the circulation is dependent on this patent ductus arteriosus. So actually they give prostaglandin E2 to maintain the patency, because patient have gland circulation or fontan circulation, because in that there is obstruction. Okay. And then they have to do bypass the venous drainage. So they, like, I don't remember exactly, one in first stage they do the gland and then they do the fontan, in which whole of the venous drainage of the body is bypassed from the right heart and directly entering the like bypassing the right heart and going directly to the lungs and things like that. I forgot exactly. So these are more details, but usually what you should be knowing, this is the chunk about congenital heart disease. Usually they will be asking, and whenever they are asking, the common thing which will come is the concern in pediatric or neonate, the physiological, pharmacological, and anatomical consideration in a neonate. Okay. So you will, because the thing is that I try to cover as much as possible, but that's why I refer to the things which I have discussed before. I will just show them to you and it will help you out. Like cardiology related, I have discussed these things before. Okay. Valvular heart disease in pregnancy, hypertension, these are perioperative arrhythmias. I have discussed in detail. PIH, pregnancy induced hypertension, uh, cardiac disease in pregnancy. If you will listen, you will get the benefit. Believe me, it's not a monetized channel. I will not get anything. But of course, not everything I can cover in 2 hours. I just try to cover because it's been 1.5 hours now about echo. Okay. And then we discuss in detail about shock, various types of shock, like septic shock, cardiogenic shock, obstructive shock. And then this is the topic which we discuss: myocardial oxygen demand supply factors, perioperative MI. Okay. MI, mitral stenosis. And so if you will listen, you will get benefit. I discussed almost uh, all the topics which you may be asked to you. Okay. Maybe some of the topics are missing and you can tell me, we can discuss this is one playlist is very important. I will share, inshallah. Otherwise you can just go to the channel and you will find in the playlist one important playlist. I will recommend you to listen is this: preoperative assessment and risk stratification. So in which actually, because this is the thing which you is being asked, so this is very important. Okay. Here, what I tell: pediatric patient for anesthetist, pregnant patient for anesthetist, renal disease patient for anesthetist. Okay. So here you will find cardiac patient for anesthetist. If you will listen, a number of things are the same which I have revised to you today. Okay. But when you are combining the things, you will again, because yesterday even I discussed the same thing, that there is one patient category, there is one surgery, and the third thing is the disease. Okay. Disease may be one, disease may be more than one, but you have to combine these three things together: surgery, surgery concerns. Okay. That what is the urgency of surgery, what is the position required in the surgery, any critical step, any bleeding, any critical thing, like tourniquet is a critical thing, lithotomy position is a critical thing, any surgery being done in prone position is a critical thing. Okay. Any like laparoscopic surgery, there is hemodynamic instability because the cardiac output will be decreased because of aortocaval compression. Okay. So this is the steps of surgery with reference to patient category, if they are putting a scenario and they have written obstetric patient, or sorry, pregnant patient, you should be knowing that there is risk of aspiration, there is difficult airway, there is the risk of embolism, there is decreased MAC, there is decreased requirement of local anesthetics. Okay, there is increased cardiac output, there are easy chances of desaturation. Okay, so these are the things, these are the common things. You can make your own smallest of the answer. That's what I'm again repeating, 30 seconds. Make a habit of making these in scenario based questions, because you don't have more time than 30 seconds. And if they want to ask something details, you can expand your answer. Similarly, pediatric patient, okay, pediatric patients are anticipated difficult airway. They desaturate very quickly, because not only they consume oxygen more, they have don't have developed this buccal handle and movement, so they don't have very good respiratory mechanics, and they are dependent on heart rate. So if there is any cause thing which is causing bradycardia, patient will collapse because the stroke volume is fixed. And then they have difficulty in IV lines. We can there is difficult in like induction. So we need to do inhalational induction. There is communication problem. There is consent issues. Okay, and there are certain things which are suspected, you have to use the special monitoring devices. You have to use smaller syringes. You have to do the diluted volumes of medication. So these are very common things about pediatrics. So you can make your own answer, revise it again and again and again. So whenever there is a pediatric patient, you open your neuron and throw out for pediatric patient. So similar answer you prepare for pregnant. Similar answer you prepare for cardiac disease patient. Similar answer you prepare for. I have tried to do it here. So if you will listen, you will get benefit. Okay. So maybe we can have some more session on cardiovascular, but because I have less time, so I just want to give you a taste, and rest of the things are here. So you can listen to the playlist with reference to cardiovascular system, and as I mentioned to you here. Okay, and then I will just show you the thing sources, because usually what they can ask you, the things which you will find them here. Okay, so for example, cardiac diseases, cardiac arrhythmias, just open and just have a look at atrial fibrillation, long QT syndrome. What are the drugs which causes long QT syndrome? Okay, carry arrest arrhythmias, actually the ACLS. Just have to know about ACS algorithms, and because I have discussed in details arrhythmias, but common things I will just quickly tell, that stable versus unstable, shockable versus non-shockable. Okay, hemodynamically unstable versus hemodynamically unstable, stable versus unstable. Okay, tachyarrhythmia versus bradyarrhythmia. Okay, arrhythmia with the narrow complex versus broad complex. These are the common things. And then any anesthetic factor like hypoxia, hypercarbia, acidosis will increase the chances. Anything like tube touching the carina, hypoxia, hypercarbia, as I told you. These are the things. Any electrolyte imbalance, any acid base imbalance will increase the chances of arrhythmia. So arrhythmias, the common things are like that. Okay, so so you can have a look at there are articles on cardiac tamponade. I think cardiac tamponade you can read from here. Usually the anything in which, like, there will be back striate, if I'm not wrong. So you can read from here, and you will find it here, because again I told you that I'm not teaching you, I'm just guiding you. There is difference between teaching and guiding. Just a second, what is the question written here? Regular versus irregular. Yes, regular versus irregular. Okay, and hypertension, you will find the important things about hypertension and ischemic heart disease. Okay, so okay, I think JNC 9 has come. So there are some articles about valvular heart disease, but the common things I have told you. The common things I have told you, and if you understand, it will become very easy for you. Okay, so valvular heart disease, ischemic heart disease, hypertension, how to monitor the case, how to induce the patient, how to give them multimodal analgesia, how to give fluid, how to anticipate any problems. So the induction and recovery is a critical phase. Okay, so just have a look here, and you will find all the required material. Okay, so yes, yes, they can ask you in talks about the CVP waveform, this ACV wave, okay, pulmonary artery, what information you can get from intra-arterial blood pressure waveform. This is very important because you can get information about systemic vascular resistance. You can about volume status, okay, how good is the contractility. You can get this information from the whether you need to give some fluid, whether you need to give some something to increase the SVR or decrease the SVR. So all these information you can get. Similarly, CVP. So you should know about ACV. And then echo, we have discussed ECG rate, rhythm, the axis deviation, P pulmonale, P mitral, and then hypertrophy, okay, and then causes, sorry, any electrolyte imbalance effects on ECG and the acute arrhythmias. So these are the things which you should be knowing about ECG. Okay, echo I have told, X-ray I have we have discussed a little bit. Cardiac enzymes I have told, you can read about them. Cardiac enzymes, there is also here, I think you will find here. I remember there was an article here. So pulmonary edema, different types of pulmonary edema, fetal circulation. Okay, fetal circulation. If they will ask, they will only ask that how the fetal circulation uh, uh, is there. Criteria for acute blood pressure reduction. Yes, Ahmed, what do you mean by acute blood pressure reduction?
Like, sir, in case of any like the hypertensive encephalopathy or hypertensive
20 to
nephropathy.
25%, am I right? Reduction, not sudden.
Right, sir. Right.
That's what you are telling?
So there are the conditions like in which we acutely reduce the blood pressure.
Usually we do like this. We try to avoid, as I told you when we were discussing, I told you that in hypertensive patients, the lower limit has gone up. So the normal limit for 60 to 160 for brain and 80 to 180 for kidney is not there. So maybe if you bring down too low, maybe it can cause ischemia. Maybe it can
Right.
cause acute renal shutdown. Okay. So I have written here about hypotensive anesthesia as well. Okay. So so same point is there in hypotensive anesthesia. You need to have urine output. You need to have, and even you have to monitor the cerebral oxygenation. So which you can do by BIS. You can do by this O3 monitor. O3 monitor. You just write intraoperative monitor for cerebral oxygenation. You will find a number of things. So you should be knowing. So whenever they are asking you about hypotensive anesthesia, yeah, they need you to tell, and there will be some contraindications. You will find a list of the contraindication in which you don't have to give. If it is too prolonged, this is a serious thing. Okay, there are certain surgery, beach chair position surgery, or anything in which this is. I think you should read about it. This is the latest AHA 2024. You will find here, and look at the recommendations. You just pass through it, and the Viva candidates should have a look here in this. Scroll it. Okay. So you see, that's what I have written here. They have written all these things: emergency, urgent, time sensitive, elective. Okay. So similarly, you will find it here because I don't have time to discuss each and everything. Unfortunately, I try to cover all the systems. So in between, if you have any question, I will be very happy to answer you. Okay. So shock is there. Shock, as I told you, that hypotensive shock, hypovolemic shock, cardiogenic shock. Okay. So you should be knowing septic shock. So you should be knowing about it. Okay, so you will find here and some words about cardiac equipment, as I told you, cardiopulmonary exercise testing, intra-aortic balloon pump. There are so much work has been done here. See, like this tutorial, this is perioperative risk scoring. So that's what we were discussing. So low risk surgery, intermediate risk surgery, high risk surgery. Yes, this is I forgot. So you should be knowing the surgical risk. I was forgetting this thing. I was repeating again and again urgency, but this is the thing which you should be knowing. That what are low risk surgery, what are intermediate risk surgery, what are high risk surgery, because your investigations will also be dependent on the surgical risk. Okay, and then there are certain either Apache 2 post some sort, and then respiratory risk factors, pulmonary. These we will discuss in different. And yes, Chad VAS score. Chad VAS score is for atrial fibrillation related problems, anticoagulation requirement. Okay. You don't need to read each and every line. You just scan through them what you need. Like if you want to learn something about cardioversion, you open it and look into the basic key points, read about like you can see about the charts, and then you don't need, again I repeating, you don't need to like monophases versus biphasic. Okay, so similarly you will just find to know the basic things what you need in any article. But in this usually they have, you see, the cardiac enzymes, as were telling you. So here you will find the about cardiac enzymes. This is, I think, old one, but I don't think so. There is another one from AAGBI. Well, usually American Heart Association, American Society of European Society of Cardiology, and this JNC. These are the things you should be trying to find the latest ones. Okay. Co-recommendation for non-cardiac surgery. Yes, Marwa, they call, it will depend on surgical risk, number one. Number two, any finding in ECG, significant finding. Then risk factors. How many clinical risk factor patient has? Okay. You know, I think I had a picture.
Yes, sir.
Okay.
Symptomatic and asymptomatic patients.
Yes, just a second. I think this is the recommendation which this is chart from the old one. Please try to have a look on the latest one. Maybe you will find something different. So the echo will be here. Echo, not all patients require echo. Okay. You will be according to, as I told you, these are the steps. The urgent surgical urgency, active cardiac condition, risk of the surgery, functional class, and then the risk factors. According to those, you will evaluate, and then you will decide if it is more than one risk factor or more than two clinical risk factors, and then you will go take the patient for echo. And one thing I forgot about this bare metal stent and drug-eluted stent and balloon angioplasty. I think balloon angioplasty you need 2 weeks. For bare metal stent you need 4 to 6 weeks. For drug-eluting stent, if it is first generation or second generation, 6 months to 1 year. First generation is 1 year, and second generation is, I think, 6 months. Okay, so so use this as a library. You don't need to be worried. Oh, so many articles, sir. How will I read? No, it's not like that. You don't need to read each and everything. You just go into it like this. I think this is the latest one. 2021. I think this is the latest one. You see, revised cardiac risk index. This is the also what we discussed actually. Heart failure, cardiac murmurs, implantable electronic devices, antiplatelet, as I told you, time sensitive, dual antiplatelet therapy, or because whenever you want to stop antiplatelet or anticoagulant, you have to do two comparison between two things: risk of thrombosis versus risk of bleeding. Okay, if risk of bleeding is more and risk of thrombosis is also more, you will do the bridging. If the risk of thrombosis is less and risk of blooding is more, you will stop the antiplatelets. This is the common antiplatelets or anticoagulants. This is the basic principle: risk versus risk of thrombosis versus risk of bleeding. Okay, my dear. So I think I will stop here. Any further question you want to ask? Yes, Ahmed. At least you are asking something, because otherwise, majority of people are sleeping. Dr. Humaira asked one question. I have answered the question. Marwa, are you clear about the question?
Yeah, Doctor, shukran. But I want to ask about the old age. Eco is recommended at.
No,
Uh-huh.
no, no, no,
Okay.
no. If you are talking, if you are working in Saudi Arabia and you are asking for echo, this is a number of time only to for medical legal purpose. We don't have any pure indication of echo only because of age.
Mm-hmm. Thank you.
Only age is not indication to do the echo. Okay. So
Sir,
yes, Ahmed.
yes, sir. Sir, what will consider in the recovery, especially in the ischemic heart disease patients? How will we proceed in recovery?
Control of pain, control of
Control
any
of pain,
stressful
right,
factor.
sir?
Okay.
Right,
And
sir.
because anything again from where which you pointed out, myocardial oxygen demand supply ratio, any electrolyte imbalance, it will cause stress on the heart, hypoxia, hypercarbia, acidosis, pain. Okay. So these are the things which you,
Hypothermia.
hypothermia, very good. Okay. So these are my best friend. Hypovolemia, hypotension, hypothermia, okay, hypoxia, hypercarbia.
Hypoxemia. Yes,
Yes,
sir. And sir,
okay,
also full bladder.
very good, very good. This is also important thing. And here in this folder you will find some topics and questions, because before I used to uh, take the classes, I used to write. So you will find a lot of important things in these folders. Okay. So a number of things we have discussed. This Goldman heart, they can ask you in Viva sometime. Coronary blood flow, yes. What are the vessels? What is right dependent versus right dominant versus left dominant? Okay. So which
And also,
artery?
sir, coronary perfusion pressure.
Coronary perfusion pressure. Yes, coronary perfusion pressure, and
How
actually,
to calculate the. Yes, sir.
yes, yes, and actually also that usually the auto regulation is not pressure dependent. Okay, this is the
Right,
local
sir.
mediated control.
Local metabolites.
Local metabolites. Okay. So you can have a look on these points. You should be knowing about transplanted. What are the consideration in transplanted heart? Because the both sympathetic and parasympathetic denervation will be there. So any indirect medications you cannot give. You have to give the direct medications. Like for heart, atropine will not act. You have to give epinephrine, or you have to give isoprenaline, who
Like
will be
isoprenaline.
directly. Okay. For any people who are appearing in basic sciences, though, they can ask you about the waveforms of cardiac cycle and action potential. They can even ask intra-arterial pressure waveform. Okay. ECG rhythm, I have told. Bradycardia algorithm, tachycardia algorithm. Okay. Glasgow aneurysm score. These are actually from the this topic of aortic dissection, and I have not discussed today. We will try to discuss in some other time with vascular anesthesia. But usually this is one file. Okay, these are the questions about hypertension. Classify hypertension. What factor determine normal blood pressure? How it is influenced by physiological. So you should be knowing about baroreceptor reflex. You should be knowing what is the role of renin, angiotensin, aldosterone system. What is the role of kidneys? Okay, how the normal blood pressure is controlled by neurohumoral factors. Okay, what BP warrants cancellation of an elective surgery? It is class 3. What are the microvascular, macrovascular complications we have discussed? Why is the significant for the anesthetic BP is high? We have discussed. So it can cause acute complication. It will put stress, increase myocardial oxygen demand supply ratio will be disturbed. Okay. Roller coaster phenomena. What is this roller coaster phenomena? When we start anesthesia, suddenly the blood pressure fall down. When do the laryngoscopy, suddenly it goes up. When we anesthetize the patient and surgery is not starting, again going BP down. And then they give the incision, again going up. So this is called as roller coaster phenomena. Okay. So a good anesthesia is that you try to avoid, because this will cause all the complications. So you try to optimize preemptive analgesia, titrated doses, intra-arterial blood pressure monitoring, blunting of stress response, titrating the requirement of anesthesia according to the stimulus. So this is the thing which can help. What are the concerns even in control hypertensive patients? So these are the all the problems which you can face in hypertensive patient meds. So I have discussed or asked a number of things. Should be knowing what are the, like what is Eisenmenger phenomena, pulmonary hypertension. So you will find a number of things. I have tried to cover as much things as I could in this 1.5 to almost it's 1 hour 53 minutes have gone. So, okay, all of you, thanks a lot for your time. And
Thank you, sir. Thank you. Sir, I think one thing is missed, like the intraoperative ischemia, if occur, then what should
I
we
have
do?
discussed MI. I have discussed,
Okay, okay, sir,
you were
okay.
not listening. I have discussed
No,
about
sir.
MI.
I think I was on Namaz, sir. Maybe I
Yes,
missed
yes. So
it.
I discussed in detail that you will stop the surgeon, airway breathing circulation. You will, if the patient, according to the hemodynamics, whether it is hypotension or hypertension, then you will immediately do the 12 lead ECG, send the cardiac enzymes, okay? And according to the surgery, whether you can give any thrombolytic, whether you can pass the NG and give aspirin, or you can give heparin according to the scenario, okay? Maybe patient needs to have pacemaker. Patient maybe, if surgical permitted, patient might need to be transferred to cath lab for catheterization. So there are so many things according to the scenario, according to the yes. So according to the scenario, you can have another important question they can ask a patient who had MI, acute or recent MI. Now it is coming for any surgery. So elective surgery will be postponed, okay? And for around it depends on what has happened, whether it is drug-eluting stunt or bare metal stunt, or what is the hemodynamic situation. So elective surgery will have different rules. If it's any emergency surgery, that like they can, a scenario which was asked to me, MI, acute MI, patient is in ICU, patient developed acute limb ischemia. So now, because this will be limb saving surgery, if they will not do surgery, the patient will collapse. So for that, risk stratification, high risk consent, explanation to the family, look into the consideration, any instability, you will may optimize that thing, and then you will proceed, because usually the vascular surgery, they are endovascular. So endovascular surgery can be done in local infiltration and monitored anesthesia care, but still you will just say, I will do the intraarterial blood pressure monitoring, cardiac output monitoring, and that's it. And if you need to give GA, all the risk, because you cannot give spinal, because the patient will be and has received thrombolytic therapy, or patient is on dual antiplatelet therapy. So in acutely you cannot do anything. So central noaxial blocks will be gone. So you can do local infiltration with monitored anesthesia care. Or if you want to give GA, all the consideration which we discussed, cardiology on board, need for ECMO, need for bypass, need for balloon, need for pacemaker, presence of T, cardiology on board. These are the things which you need to do, and you cannot delay the surgery. Okay. So thank you very much. I have shown you the link. I have shown you the questions. All these links are available in this WhatsApp channel. If anyone wants to ask any question, you are welcome. Ahmed, I would be very happy if you just drop a message on WhatsApp, so that I can be in touch with you. Okay.
Right, sir.
So
Right, right. I'm sending you, sir.
thank you very much, all of you, for your presence, and inshallah, we will continue our discussion. Bye bye.
Thank you, sir. Thank you.